Hello, everybody. Welcome. Now we're back in our lab for a RealSpine demonstration, walking you through a cervical decompression foraminotomy. I have with me today Jake Goldberg, who is one of our neurosurgery residents here, who is joining us as the assistant. And as a moderator, we'll have Rodrigo Navarro, who's our current spine fellow. So he's going to walk us through this, and I'll talk, and we'll go back and forth like we did the last few days. And today, the procedure that we're discussing is a cervical foraminotomy. I have here a RealSpine model. This model is based on a real patient that was treated at some point. The CT scan and the MRI scan were used then to reproduce a very accurate three-dimensional model using materials that resemble very much the materials that you see in real life. So the bone, the ligament, the dura. And I'm looking at this patient here now in prone position. The head is to my left. The trunk is on the right side. Now, in this particular case, or in any cervical foraminotomy case really these days, I like to use navigation for the localization of the pathology. Of course, you can do this with fluoroscopy, and that's certainly something that I do as well. But I found that if you have navigation available and you have it, especially if you have a case where you're looking at the lower cervical spine, so C6, C7, T1, where fluoroscopy sometimes can be a little bit challenging. And we talked about that at one of the sessions earlier today with Paul Park. Sometimes for localization purposes, especially if you work at C7, T1, you end up getting an AP fluoroscopy shot, and that can be obviously a little bit, cumbersome in the OR. With navigation, you don't have any of those issues. So with navigation, what I would typically do is I immobilize the patient's head in a Mayfield head holder. I would have a reference array attached to the Mayfield head holder, and then get a fluoro CT scan or a true intraoperative CT scan. And some of the new intraoperative CT scanners now allow you to modify and reduce and minimize the amount of radiation. Now, in this case, for example, where we're just using navigation for localization of pathology, I would minimize the radiation to maybe only 20% or 30% of a diagnostic scan. So that's the nice thing that you can kind of leverage with some of the newer technology. So in this particular case, we said we're going to do a left-sided C4, C5 decompression foraminotomy with a tubular retractor. So I'll just slowly get started.
Sounds good.
Thank you.
We have a question about the reference frame, but
Yes.
I think you already answered that.
Yes.
You put it on the Mayfield head holder.
Yeah, I put it on the Mayfield. In this case, for the model, obviously we have it attached to the simulation model here. But in a real patient, I would put it on the Mayfield head holder. You can also use a spinous process. However, then you have to make an additional incision, so you can avoid that. And if you put it on the Mayfield head holder, it is very accurate as long as it's just for localization, it's accurate. If I did a case for cervical pedicle screws like a C7 or T1 pedicle screws, I would probably not trust the Mayfield head holder reference, and I would actually put a spinous process clamp lower down. But for localization, it's perfectly accurate. So we scanned this patient already, and we have the navigation system here. The screen is on my right, and I'm going to show you now the spine and the localization. So this is obviously a idealized image of the spine, but you see up here the skull base. You see a C1 very nicely. See the outline of C2. I'm going to the midline now, and I'm scrolling down towards the level of interest, so that's C3, C4. So C4, C5, that's where we want to be. And whenever I navigate, I always try to, I always use two hands on my navigation tool and lift it slightly up so you don't get stuck all the time on the skin. So I lift this up with my fingers, and I glide really the fingers on the skin. And then I always try to keep the axis of the navigation parallel to the end plate. That's, and then from there you modify it as needed. In this particular case now, I'm pointing at the C4, C5 disc space. Now, what I like to do, and Evita, maybe you can help with that, because I don't want to have to go always back and count from the skull base. So what I actually do, I drop a marker into the C4-5 disc space. When I say marker, in this case, this is just a simulated screw, just simply because that's what we have as a marker here available. But I'll just ask, the fellow or the assistant in the room to drop this into the disc space, or maybe even a little bit higher, maybe a little bit more on the side, so we see it easily, or actually in the foramen, so we can see it all the time when we navigate. So let's drop it here. So this would really be then the target, right? This is between C4, C5, the left-sided foramen. That's the target that we're trying to address. So now I mark that, so I don't have to count every time I go back and navigate. And then I want to make the skin incision at about this angle. So you angle medially, and the distance from the midline is at this point is really determined based on navigation. Usually without navigation, we would say, well, we go maybe 2-3 centimeters off midline for this procedure. In this case, I don't really measure that. I just really go by navigation, and I kind of look at my trajectory, and I'm trying to depict the perfect trajectory to get down there, and then to remove the medial aspect of the lamina and the lateral aspect of, or the medial aspect of, or the lateral aspect of the lamina and the medial aspect of the facet. So I think this would be a pretty good trajectory. So I mark this on the skin with a marker. I use a 15 or sometimes an 18 millimeter tubular retractor for these decompression cases. If I do a over-the-top cervical laminectomy, I use an 18 millimeter tubular retractor. For cervical foraminotomy, a 15 millimeter. Now, in this particular case, you got to bear with me, because as good as these models are, the dilation is always a little bit of a challenge because of the material. So I make the skin incision, make a usually very superficial skin incision, and then I go deeper with the bovie, and then I make the fascial incision. Now, in contrast to a lumbar case, what I'll do here, do we have a Gelpi? I mean, a little Gelpi retractor by any chance? I forgot to ask about that before. In the lumbar case, at this point, I would basically just make a fascial incision blindly and just dilate with the first dilator. I used to do that in the cervical spine, and then it quickly became evident that there's a lot of force that you put on the spine, and there's also a lot of bleeding. So what I do now is I typically put in a little Gelpi retractor, and then I bring in the microscope. And under the microscope, I do a dissection through the muscle with 1 or 2 clamps, almost like you do a VP shunt. For those of you who are neurosurgeons, you kind of dilate through the muscle with 2 clamps and kind of create, with blunt dissection, sharp and blunt dissection, your trajectory down to the bone. When you encounter bleeding, use bipolar coagulation with a little bit of irrigation to take care of the bleeding. But in my opinion and experience now, that's really the least invasive and also the least bloody way of really creating a trajectory down to the foramen. And then once I'm down there, so I dissect down through the muscle.
So Dr. Hartl, I know it might be a little bit redundant, but could you show in this model where you're going to try to dock the first dilator? Because it's going to be
so now we have the cervical spine here. So it's all like a beaten up model here, but it doesn't have the skull base, but it has C1, C2, C3, C4, C5. So I'm trying to dock here at the lateral aspect of the lamina, medial aspect of the facet joint. And obviously you have to be careful, because if you push too hard, you can push through the ligamentum flavum here, and you potentially could get a neurological problem here, an injury. So that's another reason, obviously, why I don't push like in the lumbar spine, but I really dissect down with Metzenbaum scissors and with clamps until I see the bone, and then I confirm that with navigation. And when I'm like at this spot here, then I'll typically put in the first dilator under direct visualization under the microscope, and then I start dilating. And once you have the first dilator in, the second dilator, you're safe. You're not going to plunge through anything. So that's how I would do it. So in this case now, let's say we have dilated, we have dissected through the muscle. So now I go down with my first going back to navigation, right? Reference array. So please turn back to the navigation. So I'll show you the navigation again. Okay. So now we're back here at the C4, C5. We're back at the C4, C5 interspace. And this would be, and then I'm going a little bit lateral, and you can actually dissect with your brain lab pointer. You can actually dissect some of the soft tissues off, and you see how accurate this is. This is really beautiful. So I'm actually in the facet joint now here, and I can feel that, right? I can feel that when I use my pointer. Okay. And then you can also see here that you see the marker that we dropped there, so we don't have to count. I know now exactly because I dropped the marker at C4, 5. I know where we are. So now we got the pointer in there. Maybe you can hold the pointer here. And then I'll take the Gelpi retractor out. And now you take the pointer out.
So why do you wait to remove the pointer? I think it's for your trajectory, right?
Yeah, yeah. You want to kind of, you kind of want to maintain the same trajectory. So I now, I followed down with the first dilator, kind of the trajectory of the pointer. So now I'm in the right spot. So I use the second dilator, as Ralph Wagner yesterday pointed out. With MIS, it's always the dilation is always the crucial part for tubular, but also for endoscopic surgery. So I dilate down, and again, this dilation in this model is a little bit of a challenge because it's like rubber. The material is like rubber, and you kind of really have to work around it. But eventually, once you're down there, it's actually really nice. It's worth the effort. So now I dilate down. I can see the distance here. So this is a 50 or a 60 millimeter. Obviously, you always try to pick the shortest tube. So maybe you have 50. Yeah, let's try that one. So we put the 50 millimeter tube here. When you drop the tube, I always kind of angle away from the spinal cord, because if you go medial, also in the lumbar spine, sometimes you hit the spinous process, and then you just can't put the tube in as deep as you would otherwise. So I kind of angle away, and then I angle back medially. Now we attach it and then tighten it. We take the dilators out. And now we're going back to navigation, please. Now we're going to confirm our trajectory and placement with the navigation probe. So now this is I'm going through the tube here. I can feel the lamina, but this is C4, and now I'm going, the inferior edge of the tube is right there. So we're a little bit too cranial. The superior edge of the tube is there. So we're a little bit too cranial. Medial is here, which is fine, and lateral is here, which is fine too. So we're pointing a little bit too cranially. So what we're going to do is the assistant's going to lose the tubular retractor, and I'm going to angle everything south here. Tighten this. So I felt it kind of touching the lamina of C5. So now this looks better, right? So now the inferior edge is really over the lamina of C5, or the facet of C5 and C4. So we're in a better position. We're still not perfect. Now, as a landmark, then we're going to look for the V, the V-shaped gap between the lamina, and that would be right here. And that seems to be in pretty good position. I still want to angle a little bit further south. Okay, tighten it there. So that's good here. Thank you. So this is now better, and I'm right on bone. So this is good. So now I'll bring in the microscope.
So while we're switching to the microscope,
can we raise the table up a little bit?
Who will be your ideal candidate for this kind of surgery? Someone with a soft disc herniation, foraminal stenosis?
Yeah. So really all of the above. There's no big, in my experience, in my opinion, there's no big difference. Thank you, that's it. So, you know, patients with unilateral radicular symptoms without a lot of mechanical neck pain, without obvious instability on dynamic x-rays, you know, and these patients, I think this is a great operation. You always have the option. Obviously, you can do a fusion, you can do a disc arthroplasty as well. But if you can do a cervical foraminotomy, then most patients, in my experience, will favor that approach, because you can always go back if this fails. And the literature shows that the success rate is very, very comparable to ACDF. But if it fails, you can always go back and do ACDF or disc arthroplasty, right?
Okay. What about the number of levels? Do you do bilateral approach sometimes if you have to work on more than one level?
No, I know bilateral approach, like a slalom approach, I do if I do a multi-level cervical laminectomy for cervical spinal stenosis. That's a whole different that's a different topic to discuss. I do that as well, and in those patients I go ipsilateral, contralateral, ipsilateral, because I don't want to risk falling into a hole and then hurting the spinal cord. But in these cases here, obviously, if you do multi-level cervical foraminotomy on the same side, then I would dilate all levels first. For 2 levels, sometimes you can stay within the same. Opening, but usually I try to dilate separately before I do any of the bone work. And
they're asking, how do you deal with the bleeding? I think you have a very established routine. What do you do with the bleeding?
Yeah, the bleeding
during the approach.
Yeah, I mean the most important thing here is really the careful dissection under the microscope. So this is totally different from the lumbar spine. In the lumbar spine, you just dilate, right? You put in your big dilators. Here, you dissect it under the microscope with Metzenbaum scissors, and then if there's bleeding, you take care of it with while you're going deeper. You take care of it with the bipolar coagulation. Yeah. So that's and then you literally you can see the whole trajectory through the muscle under the microscope down to the bone, and then you drop your first dilator under direct visualization. That's my main advice for bleeding control. And then also at the end, when you take it out, you do the same thing. You bipolar on your way out. So now I am back. Now we're going back to navigation now. So I'm looking through the microscope. I already get the sense. I think that this is the V here. So let's confirm that. So we're between C4, C5, and we're right in the V, which is where we want to get started. We see our marker there on the foramen, so we know we're at the right level. We see the lamina, C5 lamina below, we're right on top of it. C4 lamina above, we're right on top of it. And then the facet joint here. And now I want to get a sense for how medial lateral, and that really depends on the pedicle. I want to, because eventually, as my bony landmarks, I want to find the pedicles. So here is the, so this would be the medial inferior, medial caudal edge of the C4 pedicle. And I kind of look under the microscope so I know where that would be, and on the navigation screen. And then the cranial portion of the C5 pedicle would be right here. So that's the C5 pedicle. So that's the other structure that I wanted to. And then I start drilling though here medially, right? So I think the tube is actually in really nice position. Now, when you with the microscope again, you always want to be in a comfortable position. So that's what I'm trying to achieve here by. Is this in focus? More or less?
It's a little soft.
Let me know because of.
Okay, you're going further away.
Okay, the other way.
Good.
That's good?
Yeah, it's good.
Okay, so it's in focus for you. It's a little bit out of focus for me because of my contacts. Yeah. But I'll deal with it. I'll deal with it. If I get a leak, then I can always blame you guys. So here, and then I'll start drilling. Here, again, the thing is I use a curved drill. I use a matchstick for foraminotomy. Sometimes I like when I do an MIS laminectomy in the cervical spine, I use a diamond burr. But so either way, I think it's fine. Still in focus for you?
Now.
Yeah, okay. So I start drilling typically medially at the inferior edge of the cranial. And I start drilling with the drill. I put the drill bit on the ligament and I go cranial.
I know you mentioned it, but I think with that view of the microscope, it would be nice if you can show us where is like your medial starting point.
Yeah. So cranial is here on my left side. Caudal is on my right side. Medial is here medially. The yellow stuff, that's actually the yellow ligament. Then this is the facet joint, lateral, right? And I start drilling, typically I start drilling at the inferior edge of the cranial lamina. So I thin this down because I want to find the insertion of the ligament, more or less, and the lateral aspect of the dura. So I thin this out, and you can see how I always rest the drill on the edge of the tube, which helps you to be steady. And then I also put my fingers or my hand on the patient's skin if possible. And the other thing that helps here, I pull out the drill bit almost like a centimeter. You see, you can have the drill bit here. You could have it here or here or here. I don't like the drill bit right underneath the shaft. I pull it out almost like a centimeter. The downside is sometimes there's more scatter, but right now there's not, which is nice. And pulling it out that far allows me to look around it and to really kind of see what I'm doing. So now I know from the navigation, I know that the pedicle is going to be right there. So I'm just drilling down the bone. Oh, see, we got a little bit caught up there. So I'm drilling the medial, the medial aspect of the facet.
You're doing something here that you do by routine, but I noticed that you put your suction on the midline and you keep drilling. So
yeah, so I always protect with my suction, right? The suction is protection, and because you saw before that I actually the scatter actually I caught a little bit of the dura there. Fortunately, I didn't get a leak, but that's certainly a risk. So, but I mean, it would be very rare to get a leak here, but it is possible. So now I thin down the bone on both sides, and now I take a 2 millimeter kerosene, and I start taking some of the bone up and down, and then so I take the bone. So the dura is here, the bone is here. So I take some of the bone here, and then you can suck up the bone, or you have the assistant take it. So I found the insertion of the ligament, and that ligament is loose. Now in a real case, there would be an epidural venous plexus here, and I try not to touch that. I mean, usually in a real case, you wouldn't see the exiting nerve root. You would see basically a lot of veins on top. So I wouldn't touch those, because if you touch those, there's a fair amount of bleeding. So now I go lateral until I find the pedicle, and now I can hit the pedicle here. I feel it. If you have the ball tip, the ball tip is here. So now I found my first landmark, or my first significant. So for the nerve root, the landmark. So that's the cranial pedicle here. You see how smooth that is? So that's the inferior medial edge of the C4 pedicle. And again, I can go back to navigation. Let's switch back to navigation. And I can confirm that under navigation that I'm at the right spot. And I am. You see how I'm just at the inferior edge of the C4 pedicle. I'm right where my target is. So that's good. So now I want to find the pedicle below, because once I have the pedicles, I know where my nerve root is. The nerve root is going to be in between, for the most part. I mean, always. So here, I bite the ligament. See how I bite a little bit, and then before I commit to the bite, I move the kerosene and I look at the dura because I don't want to accidentally grab the dura. And since I'm not in focus as much as you guys are, now I want to be extra careful here. Here, like this. So now I'm going caudally. I'm taking the ligament. Now that's the C5 lamina here. And then obviously you can see, or you can do a little bit of a laminotomy, laminectomy here. I could go more medial. I can angle the tube more medial if I think that I have to do a midline decompression as well. So now I'm going lateral, feeling for the pedicle again. So now where's the ball tip? So now with the ball tip, I'm feeling the pedicle below. See here, the smooth surface of the pedicle. So I've got the C5 pedicle, I got the C4 pedicle. I know the nerve root is somewhere in between. Again, in a real case, remember that you don't see that nerve. This is all covered with veins. And then at some point, you got to make a decision. Are you going to go through the veins, or are you happy, like if somebody just has bony foraminal stenosis, you may leave the veins there. You may just get a decompression. But if somebody has actually a herniated disc, which typically would be at the caudal end, like here, then obviously you gotta look for that disc, you know, and then you would move the nerve root up. So now I confirm with navigation. We're going back to navigation. I confirm that I'm at the correct level here at C5. See that? And with augmented reality, you know, you could mark your pedicles and you could navigate just with a microscope without a probe. You know, we do that in the lumbar spine. We haven't done that in the cervical spine yet, but you could easily just, you know, with augmented reality, just mark your C4, C5 pedicle on the left side, and then just always project it into your view as you bring in the microscope. So now I'm at the cranial end of the C5 pedicle there to confirm. So we got our region of interest. Now we know from biomechanical studies how much of the facet can you take?
Less than 50%.
Yeah.
That was going to be my next question.
Yeah.
I noticed that your approach is based on localizing the pedicle above, the pedicle below. But then at what point you start like looking at the facet through navigation?
Yeah. So now and it's always a little bit of a challenge. I mean, how do you know? I mean, what's 50% of the facet, right? They say that in the papers, but it's always a little bit hard to tell because, you know, it's difficult to measure. But I would if you look at navigation now, if you look on the left screen, I would say that where my pointer is now, it's probably in about the midpoint of the facet, right? So I would say that I can take bone up until that point. Maybe go a little bit more medial, a millimeter, but I can probably take bone until that point, and I still have 50% of the facet there. So let's look back under the microscope and see where that is under the microscope. Now we're going back to the microscope. Can you see that? So now you see here under the microscope. Oops, I gotta keep it. You see that we can still take, you know, maybe 2 millimeters here. Yeah. Let me just see here. Better?
Let's go back to the microscope.
You go back to the microscope.
Yeah.
Yeah, we're on.
Is that sharp and focus? That?
That's better.
That's better. So now you see the tip of my pointer, and you can see there's still a little bit of bone here medially. So we can take about 2 millimeters.
We have a good question. Is if you wouldn't have navigation, how would you judge how much of the facet you have?
Yeah, in that case, you know, I would angle the tube more lateral, and I would actually try to feel with some instrument, with a pen field or something, the lateral edge of the facet. You know, because you could easily here. I'm not going to do it now here, but you can aim the tube more lateral, and just you get a sense for how big the facet is.
I think for everyone in spine surgery, using the curette, the angle curette, it's like a great tool for palpate the pedicles and stuff. you have moved to use the ball tip. Can you tell us a little bit the story behind it, or why you moved to use the ball tip? You find it safer?
Yeah, I mean the ball tip is blunt, is a blunt instrument. I use it all the time. The Cret is fine too, but the Cret is bigger, right? I mean, and then with the ball tip, it really allows you to feel for the pedicle, for the smooth pedicle. With a Cret, it's too short and it's too big. You may not be able to get there. I mean, I use the Cret too, but not for this. To feel for the pedicle, the ball tip is, I think, much better. So now again, I protect the nerve root with my suction. I drill here. So I remove the medial aspect of the facet. So that's the IAP, and then the SAP is below. And you got to remember, obviously, that the nerve root compression is really from the SAP, right?
Yeah.
So I use the ball tip again here. But I also have Roten instruments. Is that in focus for you guys?
Yeah, good.
Yeah. So I can kind of. So I think that this is here. That the SAP is here. So the nerve root is under the SAP. That's the IAP here, inferior articulating process, and the SAP. So now the nerve root is being compressed. So now the other thing that I do is I look at the preoperative MRI scan and I try to figure out where's the nerve compression in relationship to the medial border of the pedicle. Because sometimes the nerve compression is pretty medial and sometimes it's pretty lateral. And since we have the pedicle here now, we can kind of orient ourselves. And then we know how far lateral we have to go for the decompression. You don't want to go too far lateral if you don't have to. So I use the ball tip here to feel, but I also have bayoneted Roten instruments that are nice in patients who have severe foraminal stenosis. Because if somebody has severe foraminal stenosis, you don't want to put the ball tip in there because it's pretty big, and the same with the Cret. So bayoneted Roten instruments are certainly available, and you can use those to kind of feel for the nerve root here. And then, do we have a 1 millimeter Carrison? I didn't ask for that before.
We have it.
And now to go lateral and really get, finish up the decompression, I use a 1 millimeter Carrison because a 2 millimeter Carrison can cause too much nerve compression, and you can develop problems, in these patients, obviously if you're not careful. So that's in focus for me, but then this is in focus for you, right? Yeah. So now we got a 1 millimeter Carrison here, and either the assistant or myself, I go backhand, and I decompress, I drill, I flatten it out with a drill before, and then I take the rest of the bone here with a 1 millimeter Carrison, and I go lateral as far as we have to do, in order then to really feel that it's nicely decompressed.
Do you use neuromonitoring for these patients?
I don't usually, but we recently used a system that is a monitoring system that you can kind of put on the those patches that you put on the muscle pre-op, and then you can stimulate nerve roots. And I've used that recently for my cervical foraminotomies to confirm then that the nerve root stimulates at a low level, and I find that actually really helpful, because one of the challenges here is always that you don't know, are you really done now with your decompression? I mean, we use all these things to kind of evaluate that, but at the end of the day, you're never really 100% sure. Now I got a nice decompression, so now I feel comfortable putting the ball tip in there, and this feels obviously totally decompressed here. But now if you have monitoring, you can stimulate that nerve, and a decompressed nerve will stimulate at 1 milliamp, maybe 2, so if so that's actually, it's also nice for the patient. You can tell the patient that you got a nice signal from that nerve. That's very reassuring psychologically.
What if you have a patient with a disc herniation, soft disc herniation from the back?
Yeah.
And you have a fragment, like a sequestered fragment there.
Yeah.
So would you just do sequestrectomy, or you do discectomy? That's one of the questions here.
No, sequestrectomy, because if a patient, most patients who have disc herniations, you'll come in here and then you'll see the disc kind of in this region. Usually it's caudal, sometimes it's cranial, but usually that disc fragment will be caudally, will be sitting right here. and then you dissect it off, you go through the venous plexus, and then you remove that disc fragment. I don't go into the disc because in order to get into the disc more, I would have to, you see here, I would have to push the dura over, and then, the disc is kind of like here. It would be very hard to get into the disc, but a fragment would be right here, and that's what I would remove. Now, when you're looking for a fragment, you got to be careful because sometimes in this model here, it's one nerve root, but sometimes you actually have two nerve root sleeves coming out, and you can mistake it for a disc fragment. Like, just imagine you have the same structure like this one, another one underneath, and you can't really see the relationship to the thecal sac. Then you can get confused, and you may think that that's the disc herniation, but it's actually the the anterior nerve root. There's sometimes the posterior and then the anterior nerve root sleeve.
I think this is pretty easy now because we don't have the bleeding factor. But how do you deal with your bleeding here at this level? Like
at
now
this
when
level,
you have the plexus?
it's really very little bipolar coagulation. Maybe I would, if there was bleeding here, I would feel comfortable with bipolar coagulation in this area to control that, and then I would have the assistant irrigate at the same time. But usually what I do is I use small pieces of gel foam. Let's say there's a lot of bleeding here, I put gel foam here, and then I continue working, and I leave that, and I go to a different location and work here, and then go back to that location maybe a few minutes later. So you kind of go back and forth.
You use your gel foam with thrombin, right?
Yeah, gel foam with thrombin, or flow seal is helpful, and but basically it's slight mechanical tamponading and some hemostatic agents, and then you leave that alone, work somewhere else, and come back to that area later. But there can be a fair amount of bleeding. The other thing I do is, the patient is in prone position, I try to elevate the head as much as possible.
Yeah, another question is, well, I don't know about this, but what is the risk of C5 palsy doing this procedure?
It's extremely unlikely. For this type of case, I don't know if I've seen that. I know it's been described, but I've certainly seen C5 palsies. Usually it's like for larger surgeries, like cervical laminectomies and fusions, where I think the palsy has to do with the amount of traction on that nerve when you kind of restore lordosis and you pull that nerve, and that nerve is being kind of pulled then after the surgery also, because suddenly that patient has like more lordosis and the spinal cord is moving backwards.
Yeah.
In this operation, it's very rare. I mean, if you have a problem here with weakness post-op, I think it's more manipulation during the surgery. And then usually what happens here is that when you go lateral, the Carrison that you use is too big and you push on that nerve. That's why I only use a 1 millimeter Carrison.
Yeah, I agree.
So and then at this point now you got a nice decompression. You can get another scan if you have you could confirm how much facet joint. It's certainly interesting. First few cases you do like that. You want to know how much of the facet did I take. In this case it's nice because we can take the tube out and we can actually look at the model.
I think we have just like mentioned and throw this fact that we do another scan, and I think for everyone they might be concerned that this is affecting our workflow too much. But can you tell us, guide us, how much it takes you to do another scan and move on into your surgery? Because I've seen it, but I think people would like to hear from you.
Can we take this off here? Oh, is it like the whole thing? No. We'll just take this off here. I just want to show you with these models, the nice thing is, and we've done that over these last few days here, we always look at the models afterwards, but you can take all this stuff off. You can actually look underneath, see that? So you can see that you see it?
Yeah, I got it on the scope.
Yeah, I think this is the most useful.
Yeah, see, that's the money shot. You can see that.
Yeah.
The facet is still intact. We took, I would say 50%, maybe a little bit less. We got that foraminotomy opening here, the laminotomy opening here. And then you can also here kind of see that if you had cervical stenosis, just by angling your tubular retractor, you can see that And we've described that. We have a video published. We have a paper. We did that with Soriano. We published a paper on that from Mexico City. You can basically do like in the lumbar spine. You undercut the spinous process, take the ligament. You can go all the way to the other side.
You mean like unilateral approach for
Yeah,
bilateral,
for bilateral decompression. Yeah. We
Yeah,
can
it
do
is
that.
possible as
Yeah.
well.
But anyway, yeah. So the scan now takes a few minutes. I mean, if you want to get a scan, I mean, now here we can't get a scan, but in a real case, you drape the patient, get everybody leaves the room, you get a spin, takes a few minutes.
Yeah.
Yeah.
Okay. Do you put your patients in neutral position or flexion for this procedure?
A little bit of flexion. When you position the patient, a little bit of flexion is helpful.
Yeah, I guess you're not concerned of fusing the patient in a
Right.
flexing position. So
Yeah.
it will always come back.
Yeah.
It makes your approach easier.
Yeah, it's like for cervical laminoplasty, any kind of decompression, you always try to do a little bit of flexion.
Okay, we still have some minutes, 20 minutes.
Pardon?
If you're gonna talk, just step away from the microphone.
Yeah.
Mayfield or Gardner-Wood tongues. I guess Mayfield. The whole point is not to move the patient.
Yeah.
Right?
So
keep it
so
stable.
when you use navigation, you're kind of committed to the Mayfield head holder. Gardner-Wells tongues are great, and I've used navigation with Gardner-Wells tongues as well, but it's not ideal. But in this, I think the traction, the tongues are a nice idea, but I think for me the navigation is more helpful. So I don't use the Gardner-Wells tongue. I used them for a while when I didn't navigate, but I don't use them anymore.
You leave anything after you finish in the defect? You put a gel foam or steroids?
Yes, I use steroids. I put a little bit of steroids. I get really nice hemostasis. I pull out the retractor a little bit, get hemostasis, and then deliver the steroids so they're not getting diluted, if possible. And then we take the tubular retractor out, close the fascia, inject Marcaine into the muscle, and then close with subcuticular closure with skin. And those patients, they all go home the same day, pretty much. Surgery. We have a YouTube channel, and we've got a lot of the spinal surgery videos. We have different playlists. If you go to the YouTube channel, the playlist, there's a playlist that's called Hartl videos. And this, so anything else? I think that's it.
I think that's it.
It's a
We
short
can go there.
operation. I mean, that's how it is. It's not a big, that's the whole point. It's supposed to be, short, sweet, effective.
Patient can go home now.
Patient will go home later. And thank you.